Good day, my dear students, and today I am going to talk about the mental status assessment. Mental status assessment we do from the beginning of our contact with the patient when we start our general survey. But there are some conditions when we need to proceed more deeper than rather only to assess the orientation of the patient or to assess whether they are confused or not confused, because this is very important, first of all, to identify that source of history is reliable for us or not reliable. So let's now, I will remind you what means that patient is oriented. As you remember, first of all, yes, we are assessing the level of the consciousness, and the alertness or the arousal of our patient is very important. So conscious patient must be alert, that is approximately like we are, so not having any troubles. And after we get this, so we know that patient is alert, we have to proceed with the questions to finding out the patient is confused or not confused, he is oriented or disoriented. So what is it, the confusion? When we ask the questions, the patient usually must give us appropriate answer. If patient fails to give the appropriate answer, looks like the confused, or they cannot remember what happened to them, we say that patient is confused. The second what we have to assess, as I told you, this is the orientation. Orientation standardly is to the person, to place, and to the time. If even one of them is not normal, it means that patient is disoriented. It's not necessary that all three parameters will be failed, but even one of them talks that something is wrong with the patient. So how we ask the questions about this? First, this is the orientation to person. The best, of course, question will be, please could you tell me the full name? Despite we always know from the medical chart, almost always we know from the medical chart the full name of the patient, but we ask him or her to tell this fully. Additionally, we can ask about the home address. We can ask about the name of the spouse, name of the children, and so on. So if patient gives us full information about his personal things, it means that he or she is oriented to person. So time the best to ask what is the date of today, what is the day of the week, like Monday, Tuesday, Wednesday, and so on. Which season is now? Which month is now? So if patient tells you the time properly, it means that patient is oriented to time. The place, of course, the best question will be where are you now? And usually, normally, if patient is not disoriented to a place, they will tell you exactly where they are and moreover why they are also in your office or in the clinic. So that is the generally which we must do with each of the patient. But we have to proceed with the mental status assessment, and even sometimes to conduct the mini mental test also, in case if we think that there are something more than the simply symptoms of the patient. First of all, let's say that in the office practice, approximately 50% of visits, they are coming together with symptoms. Symptom can be like pain, or it can be some functional disorder also, but pain, of course, this is the more frequently. And so around 25-30% of these cases, or that makes approximately 2-3 patients per day, they have medically unexplained symptoms. What does mean medically unexplained symptom? That means that behind the symptom of the patient, there is no any explanations, like either impairment in the structure, which leads to the functional impairment, or no other investigations like radiological or laboratory might confirm what is the reason for the symptom. So therefore, they are called like the medically unexplained symptom. But indeed, patient persists to come because they can complain especially about the pain, and pain could be the chronical, not responding to the standard treatment, for example, or it could be such functional disorders like irritable bowel syndrome. It could be like the fibromyalgia, which also does not have such known cause, but it leads to the multiple pains in the musculoskeletal system, like the having the trigger point and suffering from the pain, which is actually unexplainable, this pain. So whenever you have such patient, we need to proceed with the mental status assessment. Why? Because in maybe half of the cases we might see the mood disorders. That is the minimum. This is the mood disorder. So what is the mood disorder? The most frequently what we meet in our practice, this is the depression and anxiety. And although the patients who have those symptoms, they might not complain or they might not feel that they have anxiety or depression, such thorough full assessment of the mental status and given the special screening questions usually helps us to identify whether there is the problem. So we have such like the guideline what kind of patients should be assessed for the mental health screening. You understand that you should not do with each of the patient because this is time taking, but therefore we have to know what are the risk factors or what kind of conditions could be predisposing for any mental health issues which require the screening of this problem. So first, medically unexplained physical symptoms, as I told you. Or the most often exactly you will have pain, and pain will be chronic. It's not just the acute and exist in the short time, although can be another functional, as I mentioned before. So among those people who have medically unexplained physical symptoms, or again I say we cannot get any evidence which will be suggestive for the tissue damage or some changes in the labs or some evidences from the radiological examination. The best example will be like the chronic back pain. So usually we require the MRI in this case, or CT, this is the minimum what we can do, but usually we require the MRI, and we cannot see any substrata, anatomical substrata, which could be the culprit for this existing pain. So that of course will be the medically unexplained physical symptom because patient suffers, but we cannot find the reason what causes this pain. So among those patients who have medically unexplained physical symptoms, more than half might have depression or anxiety disorder. So the next one, that is the multiple physical or somatic symptoms or high symptoms count. That usually how I call this. You get to the patient who says, hurts here, hurts there, hurts here, hurts there. And what we remember from the even the history taking or what we said before, yes, that generally patient has one main chief complaint, or in elderly people it could be two or more due to the existing comorbidities. But generally it's impossible that hurts everywhere. So if your patient continues present to you to your healthcare office and accounts high amount of symptoms, then in this case we should again screen for the mental health, because probably the reason will be the same, depression or anxiety. And again, I will repeat that usually they do not say that they have kind of these complaints or moreover disorders. So high severity of the presenting somatic symptom. And this especially often happens with the pain. chronic pain. Or we are asking, how much would you rate about your pain? They will insist that it is 9, 10 out of 10. And we understand that when there is such high intensity pain, usually this is the emergency care. This is really some disaster which happens in the body, and usually such rating 9 and 10. Additionally, when we look at the patient, we might see the signs of it, like the activation of the autonomic nervous system, which will be presented like the pale skin, or patient presents with pallor. They might have diaphoresis, or they are sweating profoundly, they are restless. So this is exactly working for the intensive pain. But when your patient sits usually and tells you that they have 10 out of 10, even staying at home, you understand that that is the perception of the pain, which is how to say, they perceive it more severely rather than it is in reality. So chronic pain also, especially when we try to manage the chronic pain but we cannot manage it, we should screen for the mental health as well. Symptoms which continue more than 6 weeks. And here again, I will add up only that with the existing treatment. So treatment does not work. So we should continue with the mental health. Physician rating as a difficult encounter. So who is difficult encounter? That is the difficult patient. And you might have, and you will have in your practice, such patient. How can we recognize them? First of all, they will have medically unexplained physical symptoms. They will have high symptom count also, hurts here, hurts there. But very important also, which will be suggested, that the the very frequent visits to the offices, to different specialists. Usually they are never happy with the treatment given by the physician, because they cannot get the relief from their problem, and that's why they permanently persist to come to the office, to change even the specialist. And such people, usually physicians rate like the difficult encounter. So such patient always will present in the healthcare, and not only with the physician. Eventually those patients, they have also their relations with nurses, they have their relation in the rehabilitation with the physical therapist, and therefore we have to take into consideration. So if the condition persists and does not help any means, then as a physical therapist, for example, you can again to apply to the physician, telling about condition of the patient, that nothing helps, and therefore maybe will be necessary to proceed with a mental health screening. So the patient who has in the history recent stress, why it's important? Because very often recent stress leads to depression, but sometimes it might lead to the anxiety also, anxiety disorder. Especially if, for instance, patient says that, that recently I lost my mother, or I lost my spouse, or my partner, whoever, does not matter, who was suffering because of the cancer. And after that, they might get such like the panic attacks that they also might have the cancer. So that, or more probably, they will have depression, but sometimes it could be they can suffer from anxiety also. Low self-rating of overall health, or when patient says that you're asking, okay, how do you feel? And every time they will just complain, oh, I am so ill, I am so weak, I don't have stamina. So you understand that whenever there is the real problem, as a healthcare providers, we can identify those problems. But this everything related, like when there is no background leading to this everything. So whenever your patient always complains that they are not good, maybe there is really some reasons also, but we should not overlook the screening for the mental health. So frequent use of healthcare services, as I told you, or this is also characteristic for the difficult patient, and of course substance abuse. Substance abuse leads to different changes in the mental health, and among them, this is the very frequently will be depression, though they might experience anxiety also. So why depression? Because when they use the substances, the releasing of the hormones, of the happiness hormones, is so high that like it tires the nervous system, it exhausts the nervous system. So as a result, usually they are, or later on they start to experience depression, but sometimes it might then lead to the anxiety. Why? Because if their condition now gets some physical or somatic symptoms, then they might get anxiety, like thinking that they have heart attack, for example, they cannot breathe, they have something problem with lungs, with heart, so that often they will have depression, though possible to be anxiety. So getting the history of this everything, or we have to proceed with the screening. What we remember from the first lecture, when we discussed the history taking, or the parts of the history, you remember that we have two items there, like the substances and the sexual history, which we have to ask about only when it is appropriate, or you should not ask each patient, and it depends also in which condition you are interviewing the patient also. Yes, so you must be sure that you have the privacy during your talking with the patient. So if there is, let's say, something which gives you the background to think about the substance abuse, we are asking. When we have to ask also, when patient presents with such type of the symptoms, like the let's say it will be kind of the depression, or sometimes they will have anxiety, they might have high symptoms also, especially when they give up, or when they decide to quit the use of the any substances. So we said that the most frequently what we have in the healthcare practice, that is the among the mood disorders, this is the depression or anxiety. And how to screen them? Standardly, usually, we are asking such very sensitive screening questions. Let's start with the depression. So, over the past 2 weeks, why 2 weeks? Over the past 2 weeks, because this is the acute case. So, 2 weeks show us that this is the acute condition. Have you felt down, depressed, hopeless, or it could be kind of the informal word like in America that you been felt blue yourself, yeah? Sometimes the even there is also like the stigma, maybe for some the depression will be equal to some more serious condition. So start questions usually very very carefully related to the psychiatric history, or even the conditions, such condition. And the second question is, over the past 2 weeks, have you felt a little interest or pleasure in doing this thing? Or what has the name anhedonia? If you started before psychiatry, I guess that you will remember this term. So why this is necessary to find out? Well, anhedonia, the word, of course, you will not use with the patient. Do you have anhedonia? Because patient has no idea. That is just our term, medical term. But usually we are asking about the social life, yes, and especially when you have the young people, you know that they are very outgoing generally, even if person is a little bit introvert, anyway, they try sometime to have to meet their friends, maybe not such big circle, maybe one, two, but indeed they never go, they never isolate themselves fully. So, and this is, for instance, my patient tells me that usually I love to play football with my friends, or I like one time per week to go with my friends to have some beer, or girls might say that I like to go with my friends somewhere to the beauty salon, any of them. So when we are asking that the thing which usually brings you the pleasure, do you feel the same pleasure within the last 2 weeks whenever you do this? If your patient says no, and if even in one of them he gives you the positive for the possible depression answer, we have to proceed. First, you might have the special questionnaires, but generally, what we try to ask now, what is the main, how to say, the very risky outcome of the depression? That is the suicide. So, therefore, very carefully, we have to find out whether patient has any thoughts. Even I don't talk about the committing attempt to suicide, yes, but why it is important to find out, we never know if this really happens in the patient, and if patient has suicidal thoughts. I am not sure that when he or she leaves my office or a clinic or a hospital, they will not commit or attempt the suicide. Therefore, if we get the positive for depression, that's why we are proceeding. So, but we never can ask directly that, are you going to kill yourself? So we have to come here very carefully. So asking such question like, have you ever thought that you are not worth to live? Have you ever thought that if something happens to you, there will be nobody who will cry about you? You understand? So then very carefully we can proceed. Have you ever thought to harm yourself? We are not asking to kill yourself, harm, because they might have kind of this also attempts before trying to cut the veins or to take drugs, but eventually they might be afraid to die when this. So we need to identify, and of course after that we have to is it just the thoughts, is there was attempt or no. If they say that yes, I have such thoughts, we have to ask whether there was attempt of suicide. And of course that means that referral must be done for the psychiatrist, because nobody, no any other specialist, usually no even the family doctor usually treats the depression or anxiety or any other mood disorders. So the patient required to be sent to the psychiatrist. And here also very carefully, because of existing some bias against the psychiatrist, your patient might ask, do you think that I'm insane? So just we have to explain to educate patient. Or in Georgia usually we use the another thing, another trick, because somehow here psychiatrists among some of the part of the population still considered to be a little bit like they might feel themselves insulted. Why do you send me to the psychiatrist? Am I insane? Do you think that I'm insane? No. So the such trick, like they have right to prescribe such drugs which I don't have right to prescribe. Like this, sometimes we have to do if patient has very strong bias and might even, how to say, not accept normally the information about the referral. But indeed, this we are doing in order to identify the risk factor, and of course to involve the specialist who is in charge of the treating of this condition. So another one, this is the anxiety. And anxiety disorders, they include anxiety, generalized anxiety, social phobia. It's like they're afraid to go out. If you ask, phobia means that there is no some evidences why they are afraid to do something. Yes, so phobia usually does not have background. Fear has background, but phobia does not have background. For instance, if I give you such example that somebody has phobia of flights, yeah, so I'm afraid I will not fly. Why? I don't know. I am afraid. So I'm afraid that it will, for example, there will be the crash. We know that the airplanes, let's say the last of all, list of all they have any, let's say, such cases of the crush. But that is the phobia. If somebody tells you that, once I survived the crush, there were some problem, let's say, then it will be the fear more. It's not the phobia because it is the real background, but phobia means that, like here, social. You're asking, why are you avoiding to go to the public areas? I don't know, I feel very uncomfortable, I am feeling very bad, I feel like there is no air, and so on. So they might describe many things, how they are feeling, but they will never tell you what is the reason to avoid the society, to collection of the people. So panic disorder, that is panic disorder also when suddenly comes. Very often the panic disorder is related to the health condition. So for instance, they might get feelings that they have heart attack, and this might happen even in very young people. Like they will show, I have in my left side, because the majority who are not the let's say, who don't know the anatomy, they think that if heart hurts, it must be somehow to the left side. So they might describe even the chest pain, the real chest pain, but even if they are taken usually to the hospital because they call to ambulance, they say that they have chest pain, and that no any ambulance will decide is it the panic attack or this is the real one, because since this is the chest pain, the patient must be admitted to the hospital, and just later on it must be confirmed in hospital that there was no anything related to the heart. Yes, and it was just the panic disorder. But indeed, so this is also one thing which belongs to the like umbrella of the anxiety. Post-traumatic stress disorder, that's why we are asking, have you had any stress before recently? Yes, so the stress could be different, like starting from the breaking relation with the partner, with spouse, or losing somebody close, people who just died. So, or going through different events like the rape, like the warfare, many of them. So acute stress disorder also. So what kind of questions usually do we ask? Over the past 2 weeks, or again, we are focused on the such, let's say, acute condition. Have you been feeling nervous, anxious, or on edge? If your patient tells you yes, then we should ask the second question: was there any background to be, yes, in such condition? If such background exists, like related to the stressful job, or related to something what must be done, let's say, on time, for instance, then it could be like the relation there. Have you had something before kind of this? I would rather ask, or it's only related with this, yes? But generally, they will tell you that, like, there is no such reason to be very nervous, anxious, or on the edge, but indeed I am feeling. So that means that we are dealing with the anxiety. Or over the past 2 weeks, have you been unable to stop or control worrying? Yes, so they tell you, what about your worrying? So if your patient tells you that, my family member has cancer and I'm worrying about this condition, that will be very logical. I should not take it like this is the anxiety, because I see the real reason for the worrying. But usually the people who have anxiety, they cannot answer. It's like, they will tell overthinking, worrying about everything. I wake up in the night, I'm in panic, but I don't understand even what worries me. So that is the anxiety. Or over the past 4 weeks, have you had an anxiety attack, or suddenly feeling fear or a panic? That could be, by the way, starts usually instantly, very fast, without any predisposing factors. So they experience very often the somatic symptoms, or this is also another thing, the urge to run away, because it's like this something dangerous for them. If you ask, what are you afraid for? They will never answer you, because this is suddenly coming condition, which the such very, how say, with the autonomic stimulation, and that's why they start to experience the various of the somatic expressions. there is this panic or fear attack. So these are the special questionnaires which actually you don't need to learn. It's not your scope now. And moreover, this one usually adapted and translated for each of the country. So if you will need in your country to do, if it will be in your expertise to do this, then you will get the corresponding one. That is for what works in America usually. So personality disorders you don't need, and the border personality disorders also you don't need. So this part you don't need to learn. So in the health history, usually the most concerning and common symptoms which might have the patient, this is the changes in attention, mood, or speech. They will complain about this. But additionally also, you remember in the general survey, when we assess the patient, what we assess there also attention, or how patient listens to you when you talk to them, when you ask the question. So this is one of them which could be expressed in front of you, or they will have these complaints that you know that I cannot concentrate my attention. That could be, for example, when there is depression, but it could be when you're in anxiety also. If this is the young person, they might say that I try to learn something because I study in college or somewhere, but I cannot concentrate my attention. So why? And even they might come only with this, I have problems with attention, I have problems with my memory, but this is very disturbing for me because I am studying and it just uh, disrupts my study. So we should think about to making the screening for the mental disorders. So mood or speech. Changes in insight. So what is it is insight? Insight, that is generally what patient tells you, what they have the ideas about their condition. That is the insight. Orientation, as we said, or memory. So memory could be like the short time memory, or it could be the long time memory, which you make during the assessment usually. We check it. So unfortunately, I cannot do it with you together, because usually this I choose one of the volunteer students and we conduct the mental status assessment together. It's, by the way, very funny, but before I started recording, I found few videos. Of course, I do it fully, but these videos I chose the more, let's say, corresponding to the debates what we are learning now. So after I finish the explanation, I will show those videos that you just get idea how it is usually checked in the patients. So about anxiety, panic attacks, ritualistic behaviors, or about some phobias, and delirium and dementia. So two words about them. So how to distinguish them from each other. Delirium, that is the temporary condition which changes like the behavior of patient. It changes also the some other, let's say, the mental status of the patient. And usually, as I told you, this is the temporary. It can be caused by metabolic disorders. It can be caused by the some substances excessive by the excessive use of the substances, or it could be related to some even the poisoning, so when affected the brain. And the dementia, so as I told you, this is the temporary. So after we eliminate the reason leading to the delirium, usually the patient returns to the normal condition. While dementia, unfortunately, this is the chronic progressive condition, and this is the impairment of the cognitive function, which inevitably eventually becomes severe, or it could start manifest just with the only the changes in the memory, like forgetting something which was let's say in the very close even past, or they even start to lose the long time memory. But the problem in dementia that we cannot stop it. It's just progressing, and still there is no, we might maybe use some means to improve, but very, very temporary and in very mild degree. Actually, again, I said this is the chronic progressive condition. So what we assess usually in the mental status. First, attention. Yes, or ability to focus or concentrate over a time on a particular stimulus or activity. And that, as I told you, uh, we are checking during our general survey when we ask the questions, and by the answers I will understand patient is attentive or no. If he constantly asks me like the again to repeat my question, so the problems could be two. Either patient has the hearing impairment, and this also we have to rule out in this case, but generally, of course, the lack of attention, that means that they will not attentively answer your questions and maybe even sometimes don't answer your questions, so we need to repeat. Memory. So memory, as I told you, we are checking the short-term memory, which can be the nearest day, like late yesterday, the day before yesterday, but the long-term memory, when we have to ask, for example, we can ask the patient about their young ages, about their studenthood, when they married, if this is the elderly patient, who was the favorite president or prime minister, or who was, let's say, or we can ask some event which is very famous event, and to see whether, for instance, if my patient tells me that he is a fan of the football, and if of course I have to know the football as well, so I might ask that, for instance, do you remember who was the winner of the last, let's say, world championship, kind of this. So, and by such questions you can just be very creative here per each of the patient, so we can check the long-term memory. Orientation, or as I told you, we are asking the questions which are related, how they are oriented to place, time, and the person. And so by this I am checking like the memory, and I check the attention as well. Perceptions, or sensory awareness of the objects in the environment and their interrelationships. Yes, so this is the stimuli. So like I will show, for example, pen, and ask what is it. I will show my wristwatch and ask what is it. I will show, let's say I don't know any item, but additionally, if I show, for example, the watch, I will ask what for I use it, what for we use it. Or if I show the pen, I will ask my patient, how can we use it? And that is by this I will understand that they understand those objects or no. Thought process, and by answer of my patient I will see how logically they are thinking, coherence, or their let's say the sentences which they tell, which they say, are they like related to each other, or their speech is coherent or not coherent. So relevance of the patient's thoughts to the goals, or in general how they are thinking, because since we have the patient-centered medicine, you know that we always share everything with the patient, and we need to get their to assess their thought process also. Thought content, or now not just how logically they are thinking about what they have in their thoughts. Yes, what are their insights, what their judgments, and especially to the very often when patient comes to the healthcare provider, of course it would be related to the problem which brought the patient to us. So that is the insights, or what kind of insights? How do you think? What could be the reason for your current condition? Yes, it's very interesting to know, because some of them might tell you, that I think that I have that is inherited from my, let's say, parents, but somebody will tell you that this everything, for example, related to the stress through which they go recently, or they are even having now. So therefore, insights is very important, because that helps me later on to work with the patient in order to make the patient compliant with the treatment and adherent to the treatment. Judgment, or how they evaluate the things. affect that is generally how patient shows himself or herself, or how they behave in their demeanor, their behavior, how they try like to show off themselves. Show off, not the right, let's say, word to say, but that is how they behave. Yes, how they are showing themselves to us. Mood, yeah, especially important. Yes, what is at the moment, or mood is usual, is it elevated, or we are asking about the other times also. Yes, do you have some like the changes in your mood, like changing from the being upset, sad, and then suddenly to feel high, like to feel very happy in themselves. So the mood we assess during the general survey, what we see at the moment, but since we are doing the mental status assessment, we have to ask about the mood in other times also, which we don't know what happens with the patient. Language, so language, that is the like the let's say vocabulary of the patient. Yes, do they understand the language or no? This is also how possible to do. For example, one of them, even when you show the objects, but another thing is to ask the patient to repeat after you some sentence. Like you may say that today is rainy day, or today will be the interesting match in the TV. So, and you ask the patient to repeat after you. So, if patient does not have any problems like the fascia, for example, they will repeat after you. But aside from this, we just see how patient is talking. I don't mean articulation, that there is dysarthria. No, we are assessing how they are expressing their thoughts, or what kind of vocabulary they have. So by the language, when they tell us something, we can assess many aspects. And among them, of course, whether there is the aphasia, because if there is the aphasia, they will just miss some words which they do not understand. So higher cognitive function, and among them, that is the, of course, vocabulary. Here we have to take into consideration that vocabulary very much dependent also on the background, on the education of the patient. Yes, not just education. The patient might not be educated standardly as for us. This is having some diploma, but the person might love to read. Therefore, he has pretty such rich vocabulary. Lack of vocabulary could be related to the uneducation also. But here is one important thing, that sometimes reduced vocabulary can be the first manifestation of the dementia. Or patient is educated. So from the history, we know that, for example, he was professor in the university, or he was somewhere on the leading administrative position. Yes, so that means that he or she must have good vocabulary. So if we see that this vocabulary is somehow not appropriate with some other signs also, of course we should think maybe here is the manifestation of the cognitive impairment. So fund of information, abstract thinking. So abstract thinking, that is how to explain, that is the thing which, for instance, develops, even I can say maybe in the elementary school, even yeah, approximately, I'm not sure exactly about the exact age of the child, but the small children, they for sure they don't have this abstract thinking. Or to tell you easier, that is the, like, if I ask you now, what is it, love? So it requires exactly the abstract thinking. Yes, because nobody can give the exact explanation what is it true of. So everybody thinks abstractly about this friendship, kind of this, you understand? So the best of all to assess the abstract thinking of the patient is just to tell some proverb, like, for example, one apple a day keeps doctor away. So we do not say this is the literally, yes, and generally all proverbs, they require exactly the abstract thinking because they never express the literally meaning. So, and we will ask the patient, could you tell me, how do you think, what does mean this proverb? So if patient tells you that it means that the apple is so good for the health, that if we kind of this give you the explanation, yeah. So in this case, asking such few questions, we can assess the abstract thinking of our patient. So calculations, and usually we start with the simple calculations, but later on we can, if patient gives us the good answers, then we make it more complicated. Like from the beginning, you can ask like how much will be 5 plus 3, 5 plus 7. Then we can make it more difficult, like multiplying to each other. The more difficult usually that is the to to start from the so from 100 minus 7, so you get 93. Now from 93 minus 7 again, and to make such calculations like coming back, so it is more complicated. You can always make more complicated those calculations. Construction of objects that have 2 or 3 dimensions, here you can use just the geometrical figures, like having the paper, having the pencil, and asking the patient to, like, if you draw, for example, quadrat, if you draw the circle, sorry, the triangle, I just tell you the example, and to ask like to combine them to with each other. Okay, so the most probably that everybody will make combination and draw you the house. So that is the generally what you have to know from the mental status assessment. You don't need to go deeply here because it is more for you can read, of course, the chapter. It's up to you, but I will focus only in the things in the tests what I am talking about. So now I would like to show you some videos which I picked up, and I think that they are most of all might come to the what I am doing with students, though I don't have them full. I mean the full, like I do fully with my students, so I will try to make the combination.
I'm washing my hands. Hi, Paul. How are you?
Doing just fine.
My name is Nancy. I'm a nurse from Harper College. How are you feeling today?
Doing just fine.
All right, good, good. I am here to do a neurological assessment. Is that okay?
Okay, first you see, we introduce ourselves, as you remember, and tell our name. In mental status assessment, it's very important, and later on you will see why.
Okay.
All right, I'm going to start by just talking out loud about some things that I'm noticing, and then I'm going to ask you some questions.
Okay.
So first off, with the mental status portion of the assessment, I noticed that he is awake and alert, and that his speech is clear, and that he's appropriate. And now I'm going to ask you some questions about your orientation. Can you tell me what year it is?
It is 2016.
And can you tell me who the president is?
President Obama.
And can you tell me your name?
Paul.
And can you tell me my name?
Nancy.
Stop. Can you tell me my name? She asks. What she just now checked. Short-term memory. Trust me, sometimes after a few minutes with your patient, when you ask and who I am, that usually what I do by the end of the interview, when I play with my students, and I always give the question even much later, but she just does it very shortly, only because this is like the how to say, it's the small video for the students. The best will be usually to give this question by the end of the consultation, like when you check this everything, then you say, and who I am. And normally, of course, patient will tell you maybe they cannot memorize your full long name, but usually we do not apply like the full long name. We will say that I am, let's say, nurse Madona, I am PT Madona, I am physician, okay, and so on. We tell generally the name in such case, and we are asking them to repeat who we are.
And can you tell me where you are
Harper College,
and why are you here?
for a general assessment.
For an assessment. All right. And so from that, I'm aware then that he is oriented to person, place, time, and situation. So when we do orientation, it's not times 3, it's oriented times 4. I'm also going to ask you some questions just to do some basic screenings that we do with all patients here at the clinic. Have you had, what I want you to answer is never, or most days, or every day. Have you had situations over the past 2 weeks when you've been so anxious you really can't function?
Never.
And any times in the last couple weeks where you were so worried that you just could not stop worrying?
Never.
So she's screening him for the possible anxiety.
All right, so that has to do with anxiety. I'm also going to ask some questions about depression. Any times in the last 2 weeks where you just didn't feel like doing the things you normally enjoy?
Never.
And any days where you felt just so blue that you really felt like you couldn't really function?
Never.
So we get the negative answer for the possible anxiety and the depression.
And then lastly, a couple questions about suicide. Ever feel so blue that you felt like life was not worth living?
Never.
And have you ever, in the last 2 weeks, been so blue that you felt like hurting yourself?
Never.
Okay, so then he is negative for the screenings for anxiety, depression, and suicide. If he had answered yes or most days on any of those, then we would proceed with the rest of those screenings. And so then, moving on with there, I'm going to do an assessment of your cranial nerves.
Okay, here we don't need anymore. This is the cranial nerves assessment, which we will do later in our neurological part. So this is another example, which of course now we'll check another aspect of the mental status, and therefore I would like that you watch it also.
This picture, and I want you to just look at it and tell me what you think that picture depicts.
This looks like a mother and her son, and they're playing together, and she's giving him a piggyback ride, and they're laughing and having a fun time together.
Very good. Now what I want you to do is to write a sentence about that picture. Very good. And she wrote, a mother and her son are playing together. What I'd like you to do now is to just read this paragraph. I'm going to put your reading glasses on, that's fine. And just start right here. Just go ahead and read until I tell you to stop.
When people feel ordinary anxiety, they are usually thinking about something bad that has happened or could happen. Those thoughts seem to offer reason enough for the anxiety, but sometimes nervousness lasts a long time, becomes overwhelming, or starts to affect daily activities and relationships. At that point, it's time to think about whether an anxiety disorder is part of the cause.
Okay, very good. So what was this paragraph about that you read?
Anxiety?
Okay. And what are some of the things that would indicate that there's a problem with anxiety?
If things that you're worried about interrupt your daily activities or your relationships with people.
Very good. What is this?
A pen.
And what do you do with it?
Write.
Good. What is this?
A watch.
And good. And what's this part of the watch?
A stem.
Very good. What would this be?
A ring.
Very good. And what would this be?
A tie.
Good. Can you repeat the sentence to me, or for me? No ifs, ands, or buts.
No ifs, ands, or buts.
Very good.
And so the last one. You can find at YouTube even the mini mental test, mini cognitive test. There are 2 different types which are used for the screening and for the how to say identifying that there is the cognitive function impairment. This has right to do the family doctor also, but I'm not sure that it will be in your expertise, and therefore it's up to you. You can just watch it how to do, but you don't need to learn it how to do it.
Before testing mental status, explain the examination to the patient. In the examination, include assessments of orientation, short-term memory, naming objects, following commands, mathematical calculations, word finding, concentration, spatial orientation and construction, judgment, long-term memory, and abstract reasoning. Comprehension and expression of written and spoken language, as well as speech, can also be assessed during the mental status examination.
Hello. How are you feeling?
Well, doctor, I'm having a little problem with my memory.
Okay. I'm going to ask you some questions just to see how you're thinking. Some of them will be easy, some will be hard. Don't get upset, okay? For example, how old are you?
I'm 54.
Okay. Now, do you know where you're at today?
Certainly. I'm in Philadelphia, and I'm at Einstein Medical Center.
Very good. Now, let's say you had to call a taxi to get you home from here. Can you give general directions on how you would get home from here?
Yes, I would tell the taxi driver to take Broad Street, and then take Broad Street south to Christian Street, and left on Christian Street.
Oh, very good. And today is?
Monday.
And the month is?
June.
Very good. Okay, I'm going to tell you 3 objects, and I want you to remember them for 5 minutes. I'll ask you again later, so you repeat them after I say them.
Okay.
A red rose.
A red rose.
A black puppy dog.
A black puppy dog.
1200 North Broad Street.
1200 North Broad Street.
Why don't you try saying them one last time?
Okay. A red rose, a black puppy dog, and 1200 North Broad Street.
Very good. Now, what would you call this?
A watch.
Okay. If the tiger was killed by the lion, which animal would be dead?
The tiger.
Very good. Can you say no, ands, ifs, or buts?
No, ands, ifs, or buts.
Okay. Can you read this?
Lift up your right hand.
Very good. Thank you. Can you write, it is a fine spring day?
It is a fine spring day.
Good. Very good. Okay. How many nickels are there in a dollar?
There are 20 nickels.
Okay. Can you show me your right little finger? Okay, fine. This one's a little hard, so take your time. A lot of people can do this in 1 minute, but you relax and try and name 10 cities, 10 countries, 10 colors, and 10 vegetables. It's called Isaac's set test. Let's see. Ready? Go.
10 cities.
Right.
Okay.
Just go one to the other.
New York City, Boston, Philadelphia, Sacramento, San Francisco, Austin, Tampa, Miami, Orlando, and Chapel Hill.
Okay, keep going.
10
now.
countries. Okay. The United States, South America, Latin America, England, Ireland, France, Switzerland, Germany, Turkey, Greece.
Okay, keep going.
Oh, what was
10
10 cities,
colors.
10 countries, 10 colors.
Right.
Red, green, blue, orange, black, white, yellow, turquoise, pink, and coral.
Oh, very good. Can you do 10 fruits?
10 fruits, okay. Strawberries, blueberries, peaches, apples, oranges, kiwi, bananas, grapes.
You did great. Can you spell world backwards?
World backwards, DLROW.
Very good.
ORLD, okay.
take a look at this. It's a
Okay.
cube. Pretend it's some famous artist, like a Picasso, and you're doing a forgery. Down here, can you make a copy of that?
Sure.
Thank you. Oh, you're doing great.
A bit
Okay.
short on
a
the
little
upside.
bit short. Okay. Very good. And what were those three things I asked you to remember?
You asked me to remember a red rose, a black puppy dog, and 1200 North Broad Street.
Very good. Thank you.
Uh, so that is usually when we are checking for the short-term memory. This maneuver also is usually used when in the beginning of the assessment you say three words which absolutely not related logically anyhow to each other, and after asking some other questions or a task to be performed, after that we usually ask, please could you repeat those three words in the same sequence which I ask you to do before. So, and that is also helps to assess the short memory. So that is the generally. So as you see, there are many questions which you will be the pretty creative to ask the patient to assess their mental status, and never forget to in some let's say such cases like we have the difficult encounter or difficult patient, or when we have the medically unexplained symptoms, or we have the patient with the high count of the symptoms and so on, when we have to screen always for the mood disorder such like the depression and the anxiety. So that is for today. I will finish by this. And later, I think that the next week I will be more sure to tell you the date of the first mid exam. Rather, it will be on the seventh week, and I will write this additional to you information and tell you which portion will be included in the mid exam. So for today, I finish, and I wish you the nice evening ahead and see you in 1 week. Goodbye.